Good evening, ladies and gentlemen. Welcome to the City of York Council Health and Adult Social Care Policy and Scrutiny Committee. This is a special commissioned meeting to discuss the draft dementia 5-year dementia strategy for York. And we have apologies from Councillor Heaton and Sharon Stoltz. Councillor Norman may be joining us possibly. Do members have any declarations of interest? Councillor Cullick.
Thank you, Chair. I think it might be appropriate to mention that I have very recent experience insofar as it was only last week that I had my mother's funeral. She died very recently, having been diagnosed in September of last year with Alzheimer's dementia. And so as a result of that, I have some experience in terms of recent care within local systems. And I don't think that will prejudice me in any way. It may indeed help me to contribute more helpfully to this conversation.
Indeed, thank you very much. Likewise, actually, I do have personal experience as well in that my father-in-law died last year and did suffer from dementia as well, although not in York, so it's a different authority area. The minutes of the last health scrutiny meeting on the 20th of April, and the last full meeting of the committee, pages 1 to 8. Are members happy to? Councillor Hook?
There's a couple of things on pages 3 and 4 that say that members will be given some information, and I don't know whether we've had that or not. So halfway down page 3, when it says initiatives in mental health services were taken place to support adults, officers agreed to provide further details on these initiatives to members. And then on page 4, the second paragraph was about suicide as well. So there were two things, but it could be me because my memory is going. But
yeah, I don't. Did we have any circulated?
I don't think I have circulated anything yet, but I will certainly put it on my action list to circulate.
Thank you.
I think one was around because we raised the suicide rates, didn't we? Especially with men within York, and then there was the initiative that we've got in around some of our community mental health services. So I will make sure that I action that.
Thank you. Nothing else? Okay, thank you. Don't have anyone registered to speak in public participation today, so we can go straight to the agenda item. Pages 9 to 46 in the agenda. Jamila and Abby Hans, who's the head of transformation and adult social care, joining us for this. And are you kicking off, Jamila? Thank you.
So I'll just put it into context. I'm not hoping to go through the whole report, but I will hand over to my colleague Abby to go through the main key elements of the strategy that you have before you. And I just wanted to start off with that. You know, a strategy is needed in York just to make sure that people understand the work that we have done, and then the support and the ongoing work that we are going to be doing with people with dementia, their carers, family, friends, as well as the additional services that is needed. Lots of people have been involved in the strategy because it has been developed over a number of years. So we've had collaboration across with our health partners, with our community voluntary sector, and also most importantly with people who use our services and people who are living with dementia. But I just wanted to put in the context of York. So we have nationally, there's around 1 in 5 of us by the time we're 80. 1 in 5 of us will get dementia. 1 in 20 people will have some dementia by the time they're 60. So we'll have, but in York, we do have a much younger population who have been diagnosed with dementia. So we have a number of people who are 50 or slightly under 50. So there's a real need to say, well, how can we start doing some of that early intervention? 2/3 of people with dementia are in in the community, which is a good thing, and they're not in residential or nursing home settings, but they are then cared for by a whole range of what I call unpaid carers, families, friends, the community. And when we look nationally, that cost that is saved by us or all councils nationally is around £71 million. So you can see the amount of support that unpaid carers actually provide to their loved ones is quite high. In York, by 2030, we're going to have around 3,000, just under 3,900 people with dementia. So if we look at the national contact, nationally there are around 15,000 people with dementia. In York, by 2030, we're going to have around just under 4,000, and that's a high number. 2,500 of those will have acute needs, so they might need residential or nursing care, or sort of high needs by the time they come into service. And what we've heard from carers is that it can be quite stressful. The role of a carer can be really quite stressful, and this impacts on the person with dementia because they want their family member or whoever cares for them to have that life, but their needs are such that it's sometimes really, really difficult. And we did take that into account when we were looking at the strategy, that the strategy was not totally focused on people with dementia and their needs, but actually the wider community. I think one of the things that we've actually focused on, which Abby will come to, is how do we get that early diagnosis so we can start to work with people around early intervention, some of the prevention things which Abby will talk to you about, and then have that whole plan. I think last time we came to Scrutiny, I think one of the things that you challenged us with, which was good, was around, well, you've got a strategy, so what does that then mean in terms of actions and how you're going to deliver things differently? So that's just me setting the context. I'm going to hand you over to Abby, because the strategy, as you see, is written very differently than some strategies that you've probably come across or we've probably done in the past as well as York. So Abby, I'll just hand over to you.
Thank you, Jamila. Thank you, everyone. Yes, we've done, prior to me becoming involved actually, so I can't take credit for it, but we've done quite a lot of engagement from 2017 until present day with people with dementia and their carers, and with people with learned experience of the situation through working in professions that support people with dementia, to understand what the strategy needs to set out. And one of the reasons that the strategy does appear quite differently is because we wanted to give that message of hope. What we've heard from a lot of people is that they want it to be a hopeful vision for dementia support. So we've used the National Dementia Well pathway, which sets out the 5 areas of preventing well, diagnosing, supporting living and dying well with dementia. And what we've tried to do is say what the current challenges are nationally and locally, what we think good would look like in the city, and then what our key actions are. The strategy will be a sort of published high-level document, which is why it's not necessarily got lots of detail in it. And the hope is that that detail will be in a delivery plan, that will be a dynamic document that will evolve, and that we can hold people to account to deliver their actions on. So within the Preventing Well section, we know that in York we have a challenge to proactively seek and assess people who may be at risk and identify their condition as early as possible, to ensure that we get the right people, the right support at the right time. So some of the actions that we've identified are to work with our already established Ageing Well partnership, to work with our public health colleagues around preventative campaigns, to provide the right information and advice to people in different formats, to ensure that NHS health checks are picking up on issues around dementia and giving the right support and information there. And one thing that members of the public have said to us that they would like is to have things like dementia hubs, so somewhere to go to get the right information and see people and get timely support. So we want to work on delivering that. Within the Diagnosing Well section, we know that our diagnosis rate in York is around 50 to 55%, which is below the national average. And the target that's set nationally is around 66%. And we'd ideally like, to get above that. So we know that we want to deliver training to the health and social care workforce to make sure that they're skilled in identifying the symptoms of dementia. And we know, again, that we want to provide the right information and advice, that we want targeted support for GP practices. And that actually, from very early stages, we want people to be having conversations about advanced support planning. So whilst people have the ability to tell us what it is they'd want as the dementia progresses, we listen to that. In terms of supporting well, we know that people in York have told us that they have really varied experience of dementia support in the city. And we don't, we want some uniformity. We want people to know that they will get a good service. So again, we want to make sure we've got the right information and advice out there. We want to know that people who've had their support suspended as a result of the COVID pandemic get that back without having to go through unnecessary processes. We want to look at there's work being done nationally and regionally around having shared care records so that people only have to tell their story once. So we really want to develop that in relation to people with dementia as well as the rest of the adult social care population. And we know that we need clear pathways of support following diagnosis. A lot of people tell us they get their diagnosis and then what? There's some great work going on in the city with dementia support advisors, and we want to grow that. And to have evidence-based, person-centred interventions for people. Within living well, we know that some of our carers in York are informal carers, feel socially isolated, and that's not something that we want to continue. And we know that York citizens have said that they want improved wayfinding and signage in the city. These are things that are really important to us being a dementia-friendly community. So we need to give consideration to the spaces and places in the city which could we could encourage people to be more open and have ongoing conversations about creating the right city for people to live in with dementia. There's work going on within our communities directorate around intergenerational projects, and we really want to get involved in that and start making those connections between younger people and older people. And we already have a carer strategy delivery plan, which we need to make sure that the dementia strategy dovetails with. And then the final section of the strategy is dying well, which is a really sensitive topic, obviously, and one that some people don't want to talk about. But it's really important that we do, particularly with dementia, because it is that thing about listening to people and hearing what they want and giving people a choice where possible of where they may die. In York, actually, we've got quite a good track record of helping people to die at home if that's what they want to do. But we know that there are challenges there. There are challenges with people having care in hospital. And so we would like to, again, get the right information and advice out to people, skill the workforce up around advanced care planning and support planning, and ensure that we have the right support in place for families and carers, both at the point where the person is diagnosed as end of life, because that in itself can be a challenge to get to, because it can be really hard to understand that someone is end of life when they've got dementia. There's often comorbid conditions. So we need to make sure that families and carers are supported from that point and after. So the strategy is ambitious, as we would want it to be, but it's been developed with people and with a lot of colleagues from health and voluntary sector, as Jamila has said, and there is unanimous sign up to doing this and making this as good as we can for the citizens of York. Thank you.
Thank you, Abby. Before I open up to members, Jamila quite rightly pointed, and it's my first question is, you're probably not surprised for me to ask this. Strategy to support residents with dementia is obviously very commendable, and we've had topics previously, strategy previously from 2017 to this year, and we've had dementia-friendly city aims and aspirations that the council's spoken of in the past. So obviously this is not the first strategy. So can you remind us what the last strategy aimed to achieve, what you think it achieved and how it was evaluated and what learning's been taken from it?
So I couldn't really go in depth about what our strategy prior to this development of this new strategy actually achieved, because it was slightly before my time. I have read the strategy, really quite high level. I think the number of things that have changed, because it dovetailed with our health and wellbeing board strategy, and so does this one. It aligns with our health and wellbeing board strategy. You can see that during the development of this particular strategy, we haven't, as commissioners, we haven't actually not carried on enhancing our dementia services. So we've got the dementia advisors, our LACSA are being trained to support people with dementia in the community. We're working a lot with our dementia providers in creating the hubs and working very closely with our health colleagues. And I think a lot of work was done by the CCG, now the ICS, around primary care in increasing the number of people that were diagnosed. So this strategy builds on some of that good work, but equally focuses very much more on early intervention and prevention, where the previous strategy focused more on diagnosis and support. So there's a slight change in the way we want to move forward and deliver things in that living well for longer space than the diagnosis and support space. I think that's where you'd see the difference in this strategy.
Okay, so this is something I think the council needs to improve on, and I appreciate you're quite new in your role, Jamila, and obviously I think that's a challenge that the council has in terms of perhaps turnover within the department over recent years. But it is something that's important, because otherwise it just becomes, any document, it just becomes, it's kind of something that's launched with a fanfare, but then it actually doesn't really deliver anything. And that's kind of what it feels like with the past things. So I think we need some kind of mechanism in place. Should there be changes of staff, that things can be monitored and evaluated, and so that we can find a path for kind of learning from it.
Oh no, absolutely. And within this strategy, hence why it looks very different and feels very different than strategies we've had before. At the back of the strategy will be a whole action plan. So the action plan around the workforce and developing the workforce both internally and externally. There's things about evidence-based interventions, so we can actually monitor those. So when we review our strategy, because I think a strategy, even sometimes we have strategies that are 2, 3, 4 years. They're not actually documents that you can't revise and change, or action plans that you can't do differently. The whole purpose of a strategy is to set a vision, and then with partners and with people who use the service, change them regularly. And that's what you'll see in the difference now as we move forward, is that our strategies are going to be more co-produced and changed. With this particular one, we are hoping to come back to scrutiny every quarter or every 6 months, because we're having a steering group in place to make sure that we're delivering the action plan. Because you're quite right, Chair, you can have a really good glossy strategies that don't then actually deliver anything, or the people don't feel a change, and then it's not read by anybody. So you'll see in this strategy, it's written for people. It's not written for officers. So, and that's another difference between the strategy and the strategy previous.
Okay, thank you. Members' questions, please. Councillor Hook.
Thank you, Chair. You mentioned the dementia hubs, because I'm concerned that annual health checks that you also mentioned don't happen with my GP practice, and probably doesn't happen with others. And some of them also happen just online and aren't really genuine. So could anyone, if they think that they are acting like they might possibly have dementia, given that we've all got 5% chance once we hit 60, which is very scary statistics, we could go along and sort of self-refer?
Absolutely, and that's what the dementia hubs are for. So we're working quite closely with Nimbus Care, our health colleagues, around supporting a dementia hub, but having that clinical intervention as well. So it's not just a standalone hub, but you have clinicians to be there. But absolutely, it's there as part of our prevention and early intervention. Anybody can go have a conversation, talk about their concerns. If there needs to be a self-referral, even for yourselves or for somebody, you know, that's what those hubs are there for, and they work really well. We aren't waiting for the strategy to be agreed before we bring a hub in. We're hoping to bring a hub in quite soon, working with our health colleagues. But yes, I think one of the things that we've missed in York is a place where people can go and get information and advice more freely.
Because we all sort of go somewhere and think, why did I go there? And have I got dementia? And obviously you haven't, but you know, but people do worry, especially when you get beyond a certain age. So that would be good to know. Can I ask another question? You mentioned twice alcohol-related dementia, which I didn't even know existed, and I don't know what it is, but it sounds like that could be preventable.
Yes, yes, there are vascular dementias it's hard. It's a difficult balance because this isn't about blaming people. This isn't about saying this is your bad behaviour that's led to this. I really sort of want to stress that, but there are some risk factors that, if addressed, can prevent or reduce or delay the chance of dementia. So there are there's a Korsakoff syndrome, which is people who've had who have an alcohol-related dementia, and there are specialist services for people with Korsakoffs. But absolutely, one of the key things that public health would want us to address is some campaigning around those risk factors, so that we can educate people as to what the risks are and what choices you have to address that earlier on.
Okay, I just want to ask a kind of supplement to your first question, really. It's been discussed several times, and it's been in the local media as well, about difficulties in accessing GP surgeries. And I'm just wondering how the current difficulties are having effect on assessments for dementia. And obviously, just recently I attempted to make a GP appointment myself, and I have to say it was what I thought was a convoluted online only kind of gatekeeping that I felt was designed to keep people at arm's length. And that kind of, even though I can navigate the system, if you like, by being persistent, it would worry me that, you know, someone, a family member looking after or helping someone with dementia would find it a really frustrating process. Now, you've mentioned dementia hubs. That could be an answer to what I was concerned about. Would they be able to make a GP referral on behalf of a resident, for instance?
Absolutely, they would. So it's a two process. This one is it's the dementia hubs, which quite rightly, like Councillor Hooker sort of said, is information and advice, referral into a GP surgery, so maybe a referral into the memory clinic if it's needed. But the second bit is what Abby raised around diagnosis. We know that we are under the national average in our diagnosis. So we are looking to work with our primary care colleagues to say, how can we support people much earlier on to get the diagnosis? So it's two. It's one is getting those dementia hubs and our dementia providers who do an excellent work in the community to focus and link in more with primary care. And then those hubs. So we're not looking at just hubs in one area of the city. We're hoping to grow them. So there's a few. So there's different ways people can access services if they need to, or if they need an early, if they want to request an early diagnosis. So there's lots of different ways to do that. But I do want to stress the importance of getting an early diagnosis, because the earlier the diagnosis is, the better support we can put around the individual and their carers and friends.
Mm-hmm. So I think that's where we need to get a message out to people of how they can go about that, particularly if they're having trouble in making a GP appointment.
Absolutely.
Councillor Culloch.
Thank you. Let me first say it's good to be back on this committee. I had a year off. And I've obviously missed out on quite a lot of things that have been happening over the last 12 months. But I do have, as I've explained, a passionate interest in this. My experience over the last year has certainly not been of anything that felt like a strategy. Difficult to negotiate and compounded by all the additional difficulties through the pandemic. Nevertheless, I found myself part of a research project that was being conducted nationally, which actually proved of great interest and value. This was seeking to provide coaching for carers, both family members and carers who would be going into the home to support someone. Unfortunately, because in my particular case, my mother's case, her health deteriorated quite steeply in a fairly short time. And because this offer of coaching came rather towards the end of that, I didn't get as much benefit, and therefore the relationship didn't get as much benefit as it might have done. But I could certainly see the value of it. Without going into the detail of that, and I've looked through this, I could well have missed it, but that value of coaching, supporting carers seems to me be something that is immensely valuable and important. And I've not really seen that reflected in the strategy, but you'll put me right, I'm sure.
No, you're absolutely right. I think the strategy really focuses on carers, and we may well, and this is why I like coming to Scrutiny, because we can highlight those things that we may need to strengthen, and it's something that we could look at strengthening. In that we do, there's quite a lot in the strategy and the action plan around how we can support carers with additional training. So it's not just family-based care, but equally our independent sector. So we have lots of carers in care homes, nursing homes, domiciliary care in particular, and our own in-house services, where we want to make sure that dementia training and how to support people with dementia is there, because it can be quite difficult. And what I had one carer actually said to me, it's like I've lost the person whilst they're still alive. And it's that grieving process, and it's really, really difficult. But that coaching would be really helpful, and we probably want to strengthen it in our document. But it is absolutely there. How can we support families, the carers, with the training around what dementia is and the deterioration that may happen? I mean, in your case, it happened quite quickly. In some cases, it doesn't. It goes through many years, and it can be quite traumatic for a carer over many years. And same with domiciliary care providers. We all have the training, don't we, about manual handling, safeguarding, and caring for people with physical disabilities or mental health. And dementia always seems to be then clumped with mental health, where it's absolutely very different. And through the strategy and the work plan that Abby's got, that's where we really want to coach, to really want to support. And that coaching is a very good way, and I'll make sure that it's strengthened in the strategy.
I'm pleased to hear that, and just to explain a little more, it was offered through, let's say, a particular university that was doing a particular piece of research, but that research was working with both family carers and domiciliary carers, but only with agencies that had signed up to this particular research project, and that again was one of the frustrations in this particular instance. Because it became necessary to move to a different care provider, and with that, the whole thing just fell through in a very short time. But there was sufficient experience there for me to see that actually there could be some real value in this, and it's certainly made a qualitative difference, even for a few a few weeks. I'm absolutely confident that in my mother's case, there could have been a diagnosis long before there was, and that would have been helpful in so many ways. Not least that once she had a diagnosis of Alzheimer's dementia, she was no longer paying council tax. She was no longer, there were a number of other things that were benefits that actually she could probably have qualified for at least 12 months earlier, if not a couple of years earlier. It was only when things were getting really bad that and eventually, because of delays with appointments and everything being compounded, that it was incredibly frustrating. So I could certainly, even though my experience was a short one, just see in a small way how enormously beneficial that coaching for carers, both domiciliary carers and family members, could have been. And I'd certainly want to encourage you to be aware of research that is going on nationally. And I'd be happy outside of this meeting to just give a little bit more information about that, as far as the small experience that I have to draw on.
That would be really helpful, councillor, to have. And there's lots of research by the King's Fund around supporting carers, unpaid or paid carers, around the coaching conversations, around supporting people in a slightly different way rather than the traditional training method. So I think that the richness of information is out there, how we can do things differently. But I would welcome that conversation with you and your direct experience of that, and hopefully we can add it in our action plan of enhancing some of the training we get. Because when we say training, people always think it's the traditional, sitting in the classroom and somebody talking to you. It's a whole different way of approaching carers and people with dementia around how we it's almost about information and advice and what to expect where you have a diagnosis of dementia and what the carer should expect to see.
Yeah, what I've briefly described was none of those things.
Right.
Okay.
Thank you, Councillor Barnes, please.
Thanks, Chair. Just returning to the question of diagnosis again. The first question is really straightforward. There are two different figures in here for York's diagnosis rate. There's the infographics at the beginning. That's 53%, and then in the diagnosing well section, we've got nearly 55%. So presumably just figures from different years, but just to point that one out. So it doesn't really matter which. I suppose the more pertinent point is about closing the gap, and we've got a 5-year strategy here that talks about closing that gap both with the national average and then hitting 67% target. What will that look like in terms of the rate at which that change happens? Will we see linear improvement, or will it be a slow turning of the curve towards higher uptake and diagnosis towards the end? Have you plotted a plan for that sort of shift from where we are now to where we want to be?
We haven't actually got an implementation plan from that. We're 50, just over 50% now, and how do we get to the 67 and over? That's something that we're going to work out with our health colleagues, but certainly over the next 12 months, our expectation is our diagnosis rates will be aligned with the national average. It is a part of a assurance framework what CCGs, who are now ICSs, have to adhere to. So the diagnosis rates are part of a health assurance framework, which we need to be able to assure that all our population are getting diagnosed in the correct way. Hence why we're looking at a 12-month plan around this, but we haven't actually got the trajectory in place. That'll be something that we'll finalise once we've got the strategy in place and the steering group to have that oversight of.
Okay, thank you. Can I just follow up, just check I've understood correctly? I appreciate there's work to be done in terms of operationalising, but are you saying that the aim is for the ICS to hit that 67% target by the end of the first year, rather than kind of a gradual climb up to 67 at year 5?
Yes, that's what we're
Excellent.
hoping.
Okay, that's reassuring. Thanks.
Thank you. Under each of the preventing, diagnosing, living well and dying well sections, the document references some key actions and priorities, but doesn't have any baselines, timescales, resource implications, or metrics. Now, I know, Abby, you referred to accountability earlier on. So are these something that are going to be added, and how will they be monitored?
So they will be the focus of the delivery plan rather than the strategy per se, because we want that to be the dynamic part. We want the strategy to set the vision and the sort of high level achievements, and then we want the delivery plan to go into that more granular detail about who's going to do what, by when, how. And how is that going to be monitored and measured? There are some challenges around measurement nationally for dementia, and we need to sort of get really underneath what that means for us locally. So that is in development as we speak, really. The delivery plan changes on a day-to-day basis as we're having the conversations. And I would hope that, so we are on target for, as long as everybody internally to the council and the public, when we do a consultation event with them, as long as everybody's happy, we're on target for publication of the strategy in September, and the delivery plan should have those metrics in there at that point.
I notice Healthwatch publicising some consultation work. Clearly, obviously, I'm guessing you've asked Healthwatch, and you're working with them closely on that. How else are we consulting with people, would you say?
We have a monthly working group with members of the voluntary and community sector who are taking sections that we're struggling with, or that we think we need more information, out to groups of people with dementia and their carers to talk about. So there are dementia support advisors, there are people with lived experience who are supporting other people with lived experience, who are going out and sort of having those conversations, and then coming back and rightfully challenging us and holding us to account on that. There has been sort of quite a long legacy of engagement events, so we do recognise that in this period what we've been told is that people want this delivered because they really want us to get to the delivery planning bit. So other than the consultation event on Monday, it is just those links out through the community organisations.
Okay, thank you. Any further questions, members? I've got one more. Given the local authority is continuing to step back from the direct provision of care, and this is something that's evolved over the last couple of administrations, really, and how confident are you that sufficient, affordable, quality care is available in the for-profit sector?
So I think as a council, we're looking at what is the best way to deliver care, both through our independent sector and internally. And I think what we're trying to do is have a mixture of both. We've got workforce challenges both within our provision. As you know, the council provide its own domiciliary care provision by PSS. And we are working really closely with our health colleagues to devise what we're calling a reablement and intermediate care, sort of an early intervention prevention pathway that will include older people with dementia, and that'll be an internal health and social care provision. The second bit is around developing our market, and Abby again is setting our, as you know, market position statement of exactly what we would expect from our external providers to provide and what care they will provide. So it's a balance of the two. We're not actually saying that the totality of the care that we want to deliver will be delivered by our external market. There are work that we're doing between health and social care where we want a pathway approach into early intervention, prevention, ongoing care, and then 24-hour care.
I guess I'm trying to have some reassurance about people that generally can't afford perhaps some of the fees that the market guides us towards, and how the council, what assurance the council can give that there will be suitable accommodation for some people that are suffering from dementia, and that don't have the family support perhaps that many people have, or if they do have, it's sometimes unrealistic to expect family to take up all that, so that kind of intense support that might be needed. Just want to make sure that no one falls through the gaps. So how would we make sure that?
Yeah, absolutely. So if we're talking about paying for care, we've got people who are assessed whether they can afford to pay for care or not, and then we have a whole self-funder market where, as a council, we always provide self-funders with the option of having a assessment and making sure that they are assessed for their needs and then pay for the needs that they have. But at the moment we are it's a national programme, so regionally with the other local authorities we're doing what's called a fair cost of care analysis, and that is working with our providers to say, well, in York, what would the fair cost of care be, and set a fair cost of care rate, so we're not having people paying depending on how they've accessed services, lots of different rates. At the moment, you are quite right, there are lots of variable rates that people are paying. Some people can pay £2 or £3 extra than another, and and agencies can charge quite variable between each other. But we're hoping that the fair cost of care analysis will actually level that market out and say, well, how can we support providers to deliver, because they have to be viable, but then equally, how do we support residents to be paying that fair cost and not be overcharged or not be able to access the right service. So that fair cost of care analysis will be concluded in the autumn, and we should get the results back in, say, to September, October time. But every individual, regardless if they're self-funding or not, can actually ask the council to do an assessment for them under the Care Act.
Okay, thank you. What kind of current capacities do you think there is in the market for reasonably covering the potential increase in need as the old, as people get older, generally in the population, specifically for this kind of specialist care?
So we did have an analysis done, part of the Better Care Fund, and the feedback we actually got was that there is enough care within York. So the care we've got through our domiciliary care, our 24-hour care, the nursing or residential care, we do have sufficient amount. What we don't do well, or what we need to improve on, is actually making sure that the care is accessed at the right time. So we've got lots of people accessing care very early on, and then crisis care, so 24-hour care, and that middle bit of, and this is where we talk about early diagnosis, early support. How can we then start from the pendulum from early intervention straight into 24-hour care? I think if we manage to support people throughout their journey, there is sufficient care within our community, within our providers, to support people, even with the increases that we see by 2030. It's about getting the support we provide to people at the right time in the right place.
Okay, thank you. And kind of linked really, but you just need to look on some of the websites and see the volume, huge volume of particularly part-time vacancies in the city at the lower end of pay scales generally, and that's where care workers unfortunately always seem to fall in terms of the pay scales as well. Is there any sign that this is creating an issue in York specifically, in terms of providing safe care, because of the, whether the shortage in a particular care setting, which could mean that the residents are not getting the care that they deserve. Is there any sign of that currently? Because there do seem to be a lot of vacancies.
Workforce challenges are, so York is not unique in its workforce challenges, and being able to recruit and retain staff both internally and externally. I think what we haven't seen in York, like we've seen in other areas, is where lots of providers have handed contracts back because they no longer can get the work, or they no longer can provide safe care. We haven't seen. We've had a few. I think we've had 3. But we haven't had a lot. What we can say is at the moment, the care that's being delivered is safe. There's no evidence to say that there isn't. We work quite closely with CQC on to make sure that the care is safe, but plus we've got our own internal contracts and quality assurance to support that. But challenges in the workforce and being able to recruit, I think, is going to be a longer term issue, but we are looking to recommission our domiciliary care contract, and that will give us an opportunity to work with our providers to say what would the minimum wage look like. Should we move to the national wage? What is moving towards more contractual care rather than people who work on who are paid by hour, or have flexible contracts. I think one of the things that we can change as we move forward is to say providers to have more contracted hours with their carers, and that will help with recruitment rather than at the moment where it's really quite a very flexible market, which then creates your part-time issues that we're looking at now. But I can say at the moment we haven't had any significant safeguarding issues or any significant issues around the quality of care that's being provided.
Thanks very much, Jamila. Any further questions, members? No? Well, in that case, we'll look forward to seeing how this develops as a strategy, and look forward to some updates coming forward at future meetings. Obviously, I guess that there'll be input at the Health and Wellbeing Board, because it's an item coming up shortly, isn't it? And that perhaps will benefit from having the whole kind of associated partners around the table to input into that, which is clearly going to be important as we go through a new phase with the changes towards the ICS and etc. Okay, thanks very much. Right. So I don't have any other business as such. We do have another meeting next week, which is a combined meeting with the Corporate Scrutiny Committee, and that's to focus on the draft 10-year health and wellbeing policies for the council. So I'm guessing that there'll be some interesting discussions there, and I guess there's same kind of questions about comparisons with the past, I think, will be asked. Because I think that is an element that we've not been good at, and I'm not pointing the blame at anyone here, but just generally as an authority over the years. So I look forward to seeing that change. If there's nothing else that members want to raise currently, I'll draw the meeting to a close. Thank you very much.